Welcome to ABC tutorial. Today we'll be talking about caffeine toxicity. Caffeine is a naturally occurring CNS stimulant of the methylxanthine class. It is the most widely consumed stimulant drug in the world. It is present in medications, coffee, tea, soft drinks, energy drinks, and so on. Caffeine's primary mechanism of action is on the adenosine receptors in the brain. Because it is both fat and water soluble, it crosses the blood-brain barrier easily, resulting in antagonism or blockage of all the four subtypes of adenosine receptors, which are the A1, A2A, A2B, and A3 receptors in the brain. The blockage of the A2A receptor is primarily responsible for the wakefulness effects of caffeine. Adenosine receptors are not only found in the brain, but are present throughout the body. In the cardiac muscles, direct antagonism of the A1 receptor results in positive inotropic effects or increase in the heart rate. At the level of blood vessels, caffeine undergoes a complex interaction to control vascular tone, which includes direct antagonism of vascular adenosine receptors to produce vasodilation, as well as stimulation of endothelial cells to release nitric oxide, which further causes relaxation of vascular smooth muscle cells. However, adenosine receptor antagonism in the system stimulates the release of catecholamines, which can counteract the vasodilation effect produced on the blood vessels. Thus, the overall effect of caffeine in the blood vessels is individualized and dependent upon the dose of caffeine, the frequency of use, and comorbidities such as diabetes or hypertension. Overall, caffeine seems to increase systolic blood pressure in individuals with infrequent use. However, there is little to no acute effect on habitual consumers. Blockage of the adenosine receptor also stimulates respiratory drive by acting on the respiratory center in the brainstem. Caffeine increases renal blood flow, glomerular filtration, and sodium excretion in the kidneys, resulting in diuresis. It is also a potent stimulator of gastric acid secretion and gastrointestinal motility. Metabolism of caffeine primarily occurs in the liver via the cytochrome P450 oxidase system, specifically the enzyme CYP1A2. Metabolism results in production of any of the following: paraxanthine, theobromine, or theophylline, each with unique effects on the body. These metabolites are then further metabolized and excreted in the urine. The half-life of caffeine in the average adult is approximately 5 hours. Half-life is reduced to about 2 hours in smokers compared to non-smokers. Conversely, people with prolonged half-life and potential for toxicity include pregnant women, especially those in the final trimester, who can have a prolonged half-life of up to 15 hours. Newborns also have significantly prolonged half-life of up to 8 hours for full-term infants and 100 hours for premature infants. This is due to reduced activity of cytochrome P450 enzymes and immature demethylation pathways. Additionally, patients with liver disease or those taking cytochrome inhibitors will also experience prolonged half-lives due to reduced enzyme activity. If acute caffeine ingestion is suspected, patients or witnesses should be questioned about the use of prescription medications, over-the-counter drugs, and illicit drugs such as cocaine, amphetamines, methamphetamines, and so on. The patient and witness may also give history of recent behavior compatible with caffeine use, such as trying to lose weight or taking stimulants to aid in working or studying. Sometimes, pill bottles found at the scene may provide a clue to what the patient ingested. When ingested chronically in excessive amounts, caffeine produces a specific toxin drum known as caffeineism, which consists primarily of central nervous system, cardiovascular system, and gastrointestinal system hyperstimulation. Central nervous features include headache, lightheadedness, anxiety, confusion, psychosis, and even seizures. Palpitations and chest pain are cardiovascular features seen in caffeineism. In the gastrointestinal tract, there could be nausea and vomiting, abdominal pain, and diarrhea. Vital signs may reveal tachypnea and tachycardia, widened pulse pressure, and hypotension. Other examination findings include tremors and seizures, altered mental status, dilated pupils, and hyperactive bowel sounds. History of excessive consumption of caffeine-containing products is generally enough to make the diagnosis alongside examination findings. However, the following laboratory studies are indicated in patients with moderate to severe symptoms of caffeine toxicity: a complete blood cell count, which may reveal elevated white blood cell count; serum electrolyte, glucose, blood urea nitrogen, and creatinine concentration should be checked. Particular attention should be paid to potassium concentration and the anion gap, because hypokalemia and high anion gap acidosis is a classic feature of caffeine overdose. Routine screening for other potentially treatable toxins such as acetaminophen and salicylate are recommended. Such testing is essential, especially if the patient ingested analgesic medications containing caffeine combined with other drugs such as excedrin, cafegus, and so on. The total serum creatinine kinase concentration should be checked, especially when rhabdomyolysis, which is sometimes associated with severe caffeine toxicity, is suspected. Urinalysis may reveal rhabdomyolysis, myoglobinuria, glucosuria, and ketonuria. Serum caffeine concentration determinations do not influence management because caffeine tests are generally available wholly at reference or research laboratories and are not routinely measured clinically. However, serum theophylline concentrations are more rapidly and widely available. Because theophylline is a minor metabolite of caffeine, a positive theophylline assay may be helpful in confirming suspected caffeine toxicity. Stable patients with only mild symptoms do not require imaging studies. However, it is good to obtain a chest radiograph in patients with chest pain, fever, or respiratory complaints. In patients with seizures or altered mental status, a cranial CT scan should be considered. Patients with chest pain, palpitations, tachycardia, or an irregular heart rhythm should be evaluated with an electrocardiogram. Fatal caffeine overdose is relatively uncommon. However, prognosis largely depends on how quickly treatment is implemented. The primary treatment for minor cases of caffeine toxicity is supportive. Hydration may be oral in minor cases, yet severe cases benefit from intravenous hydration. Beta blockade with esmolol is useful for tachycardia. Procainamide, lidocaine, or bicarbonate have also been utilized for the treatment of arrhythmias. Vasopressors such as vasopressin and phenylephrine can be used to maintain blood pressure without worsening the tachycardia. Activated charcoal can bind caffeine if the ingestion is recent. Hemodialysis has been effective in severe life-threatening caffeine ingestion.